Welcome. This is a very important topic. I cannot tell you how many patients come in to see me with chest pain and are having AMI. It's very important for you to recognize acute coronary syndrome immediately. Most patients with chest pain, however, do not have an MI, and a systematic approach can usually rule it out. This depends on where you work and what tests you have for point of care. For this presentation, I will focus on recognizing acute coronary syndrome and differentiating it from stable angina. I will then focus on treatment of post-acute coronary syndrome and treatment of stable angina. In the United States, coronary artery disease is the leading cause of mortality, with more than 300,000 deaths annually. Each year, more than 600,000 persons will have their first MI, and nearly 300,000 patients with known coronary artery disease will have recurrence. Each year, approximately 1.5% of the population consults with a primary care provider for symptoms of chest pain. When signs and symptoms develop, the disease is very advanced. There are several theories of atherogenesis. Most likely, it's a combination of these theories that cause atherosclerosis and a resulting MI. Endothelial injury from hypertension, lipid accumulation, or chemicals releases factors that cause lipids and other clotting factors to accumulate. With lipid infiltration, lipids are trapped in the smooth muscle and cause damage. Aging literally causes hardening of the arteries. Thrombogenesis forms a blood clot, usually over a ruptured plaque. Besides causing endothelial injury, hypertension causes increased lipid infiltration. Inflammation of the plaques increases the chance of plaque rupture. 85% of deaths for coronary artery disease are greater than 65 years old. More males have coronary artery disease than females, even after menopause. An early family history of coronary artery disease is considered as a first-degree male relative with the first event before 55 years of age, or a first-degree female relative with first event before 65 years of age. The presence of chronic kidney disease is a major risk factor for developing coronary artery disease. Clinicians should be aware that the risk of dying from cardiovascular causes in patients with chronic kidney disease is significantly higher than developing end-stage renal disease. Furthermore, rates of restenosis following percutaneous coronary intervention are worse in patients with advanced renal failure as compared to those with early stages of chronic kidney disease or patients with normal kidney function. Cardiovascular disease is the leading cause of death among people with type 1 and type 2 diabetes. Coronary artery disease is the cause of death in more than half of all diabetic patients, and many are debilitated by symptoms of heart failure or angina. Obviously, known atherosclerosis anywhere in the body increases the likelihood of its presence in the coronary arteries. Coronary artery disease is higher in Hispanics, American Indians, and Native Hawaiians. The incidence of coronary artery disease in Black women is 72% higher than white women. Use the 10-year risk calculator discussed with lipids to determine the risk for coronary artery disease. This is the table from the American Family Physician article. Note that if 4 or all of the variables are present, the positive predictive value is almost 63%. In my experience, most patients do not think the pain is from cardiac origin. I usually have to convince them otherwise. When a patient comes to the office with chest pain, obtain an EKG as soon as possible. I would definitely take the EKG class offered at NIU. EKG changes are used to diagnose a myocardial infarction and to locate the area of damage. Injured cells function but do not fully polarize or attain the ability to generate an electrical current. The T wave first becomes tall and pointed, or later becomes inverted at the same time as ST elevation. The area of ischemia is reflected in T wave changes, usually T wave inversion. The area of injury that looks like a fireman's hat on EKG is an ST elevation MI or STEMI. The patient needs to be immediately transported via EMS to an emergency room. An EKG without a STEMI is considered a non-STEMI, a term that is actually no longer used. Instead, non-ST elevation acute coronary syndrome is used. That includes a non-STEMI and unstable angina. In addition to ST elevation, new or presumed new left bundle branch block could also be an indicator of a STEMI. The area of infarction results in permanent Q waves. These show hours after the MI. Once Q waves are present, they are always present since the cells are dead. So you cannot tell when the infarction occurred without comparing it to previous EKGs. Transmural infarcts are infarctions of full thickness of the ventricular wall. A transmural infarct usually presents as an ST elevation MI. They also develop Q waves after the MI. The other types of muscle infarction usually do not show as a STEMI and usually do not develop Q waves. They are again labeled as non-ST elevation acute coronary syndrome. I do not have the means in my office to draw and test for troponins. My thought is that if you really need troponins drawn, you probably need to be in the emergency department. Troponins I and T are structural components of the cardiac myofibril. They are released into the bloodstream with myocardial injury. The cardiac isoforms are very specific for cardiac injury and are not present in serum from healthy people. Troponin, if negative, should be remeasured later. For the older troponins, it would be remeasured in 6 hours. There are newer troponin assays that can detect levels earlier. Patients with no signs of ischemia on EKG and an initially undetectable high sensitivity troponin T or I level using one of the new high sensitivity assays have a very low likelihood of acute myocardial infarction or 30-day mortality. If the troponin is detectable at low levels, it should be remeasured in 1 to 2 hours. If there is a small increase, it is unlikely that the patient has an MI. If there is no evidence of STEMI, the patient's risk of acute coronary syndrome should be categorized as low, intermediate, or high using this table. This is based on an assessment of risk factors, presenting signs and symptoms, and serial cardiac troponin measurements. Because of the lack of availability of troponins in most primary care offices, patients with chest pain and risk factors should be sent to the ER unless there is some other readily apparent cause of it. Most other diagnostic tests are to rule out other causes of chest pain. Chest X-ray, CT, and an echo can identify a pneumothorax, pneumonia, aortic dissection, cardiac tamponade, pulmonary embolism, severe valvular disease, and hypertrophic cardiomyopathy. An echo, stress testing, and CT angiography can identify cardiac ischemia also. If using a stress test, a stress echo or nuclear stress test are preferred. Angina is chest pain that is caused by blockage or spasm of a coronary artery to cause reduced blood supply to the myocardium. It is not total elimination of the blood supply as in an MI. The chest pain is brought on by supply versus demand, which is why activity and stress can trigger angina. It can also be due to lack of oxygenation of the blood, as in anemias. Here's some common sites of anginal pain. Notice that it can be basically anywhere on the upper torso and it radiates to the left arm. And just an FYI, that's why we wear our ring finger on the left hand, on the left finger, ring finger, because that's typically where the pain from the heart radiates to. But it can also radiate to the neck and jaw. Stable angina is predictable and caused by similar precipitating factors each time, such as exercise, emotional upset, or tachycardia. If the patient rests or takes a sublingual nitroglycerin, it typically goes away. In patients with stable angina, if symptoms are not significantly improved by one dose of nitroglycerin, they can repeat the nitroglycerin every 5 minutes for a maximum of 3 doses. If the chest pain becomes worse or does not go away, they should call 911. Stable angina can be medically managed for long periods. Unstable angina, however, non-ST elevation acute coronary syndrome comprises unstable angina and non-STEMI. Acute coronary syndrome is a combination of STEMI and non-ST elevation acute coronary syndrome. A myocardial infarction is a term used to describe irreversible myocardial necrosis or cell death from an abrupt decrease or total cessation of coronary blood flow to a specific area of the myocardium. The extent depends on collateral circulation, anaerobic metabolism, and cardiac workload. Symptoms suggested of cardiac ischemia include retrosternal chest pain, with or without radiation to either arm, the neck, or the jaw, oppressive chest pressure, abdominal pain, dyspnea, nausea, vomiting, diaphoresis, and syncope. The The nausea and vomiting are from pain or stimulation of the vagal nerve in the area of infarction. In older persons, those with dementia or diabetes, and women, ischemic discomfort may present atypically, including epigastric discomfort, indigestion, pleuritic chest pain, and dyspnea. This is another chart from the American Family Physician. Note the findings with the highest sensitivity, such as a history of coronary artery disease, diaphoresis, similar pain to previous episodes, pain in the left arm or shoulder, an absence of chest wall tenderness. Note the other EKG changes, other than ST elevation, are much lower predictors. Always be sure to send the patient to the emergency room if you are unsure of the reason for chest pain. You do not want to miss this diagnosis. Now we are switching to post-acute coronary syndrome or post-hospitalization care of an MI and stable angina. Controversy over using stents for stable coronary artery disease will increase the focus on optimizing medications instead. Recent evidence suggests coronary stents do not improve chest pain more than optimal meds in patients with stable, not unstable, coronary artery disease. Sublingual nitroglycerin should be used for immediate symptom relief, whereas beta blockers are the initial therapy for long-term relief. Beta blockers are recommended first line for angina relief. Agents that are cardioselective for blocking beta-1 receptors are preferred to minimize the risk of adverse effects. Those include metoprolol, atenolol, and bisoprolol. Some beta blockers have been shown to improve survival in patients with heart failure with reduced ejection fraction or post-MI, and those include carvedilol or metoprolol, and it's metoprolol succinate. Beta blockers improve survival and reduced MI reoccurrence in patients with a recent MI and in those with abnormal left ventricular function. Adherence can be compromised by side effects such as fatigue, sexual dysfunction, which is a major one for males, sleep disturbances, and cold extremities. For patients with peripheral artery disease worsened by beta blockers, consider carvedilol. A calcium channel blocker or long-acting nitrate should be added if beta blockers do not control symptoms. Calcium channel blockers can be used as first-line therapy in patients who cannot tolerate or who have a contraindication to beta blockers. Calcium channel blockers reduce chest pain, improve exercise tolerance, and reduce risk of reinfarction post-MI, but do not improve post-MI survival. The reduction of the risk of reinfarction is by the non-dihydropyridines. Non-dihydropyridines block entry of calcium into cells at the SA node and AV nodes, reducing the ventricular response, thus making them suitable for the treatment of angina. Long-acting diltiazem or verapamil can be used instead of a beta blocker for symptom relief, especially if a beta blocker cannot be used. Generally, avoid verapamil or diltiazem in addition to beta blockers and in patients with heart failure with reduced ejection fraction. Use a dihydropyridine such as amlodipine or felodipine instead. Dihydropyridines act predominantly on the blood vessels to cause vasodilation. Common dihydropyridine adverse effects include headaches, dizziness, palpitation, flushing, and peripheral edema. Long-acting nitrates are beta blocker alternatives or add-ons. Reserve ranolazine for patients who cannot tolerate or do not get adequate relief from the angina meds listed above. You can combine with other angina meds or substitute for a beta blocker. It is not more effective than other angina meds. It reduces angina frequency and improves exercise tolerance, but does not reduce MI or death. It is well tolerated, but causes QT prolongation, has many drug interactions, and is more expensive than other anti-anginals. Ensure that patients with coronary artery disease are on the correct antiplatelet regimen. Stick with aspirin, 81 milligrams a day, indefinitely. Higher doses are not more effective and increase bleeding risk. Clopidogrel may be used instead of aspirin if they are intolerant of aspirin. Keep in mind to save dual antiplatelet therapy, which would be aspirin plus clopidogrel and the others listed here, for patients with a recent stent or acute coronary syndrome. Use dual antiplatelet therapy for at least 12 months in these patients, and then continue with aspirin indefinitely. Ensure that patients with coronary artery disease post-MI and or with heart failure with reduced ejection fraction are on an evidence-based beta blocker and ACE inhibitor or ARB. For beta blockers, the dose can be increased weekly as tolerated to the target dose. In patients with systolic heart failure, start the ACE inhibitor or ARB, then increase the beta blocker to the target dose over about 12 weeks. They do need to have reduced dosage in renal and liver impairment. Minimize hypotension by giving the beta blocker and the ACE inhibitor at different times. Usually, I give the ACE inhibitor in the morning and the beta blocker at night because the beta blocker can cause fatigue. The resting heart rate goal is 55 to 60 as tolerated. In patients with normal systolic function, benefit is greatest within the first 3 years after the MI. ACE inhibitors are used for patients with ejection fraction of 40% or less, hypertension, diabetes, or chronic kidney disease. You may increase the dose after 1 to 2 weeks. Check the potassium, serum creatinine, and blood pressure within 1 week of initiation or dosage increase in the elderly, and within 1 to 2 weeks of dose increase in others. Recheck in 3 to 4 weeks if stable. ARBs are used for ACE-intolerant patients, mostly patients with a cough, and monitor as in the ACE inhibitors. Ensure that the patients are taking a statin per guidelines. The therapy should be initiated if the patient has a 10-year risk of greater than 7.5%. You can consider it if their 10-year risk is 5 to 7.5%. If they have known cardiovascular disease, use a high-intensity statin for patients 75 years of age or younger, or a moderate intensity statin for patients over 75. Ensure that coronary artery disease patients with hypertension have their blood pressure under control using appropriate therapy. Aim for a blood pressure of less than 130/80. Reduce the blood pressure slowly in patients with ischemia. Keep the diastolic blood pressure greater than 60 in patients with acute coronary syndrome, patients with diabetes, and patients who are greater than 60 years of age, and with left ventricular hypertrophy, and this is to maintain cardiac perfusion or coronary artery perfusion. An ACE or an ARB is a first-line agent for most coronary artery disease patients. The guidelines also include the option of a beta blocker. A beta blocker is probably not the best choice for chronic hypertension management unless the patient has another indication, such as post-MI or heart failure, due to the poor tolerability and unimpressive outcomes data for hypertension. Beta blockers reduce angina symptoms, and post-MI or heart failure with reduced ejection fraction patients will need both an evidence-based beta blocker plus an ACE inhibitor. Bisoprolol, carvedilol, or metoprolol succinate are preferred in patients with heart failure with reduced ejection fraction. Avoid atenolol. It does not reduce CV events in these patients. If needed, add a dihydropyridine calcium channel blocker, especially for angina despite a beta blocker, a thiazide, or a mineralocorticoid blocker such as spironolactone. Consider indapamide, which is Losol, or chlorthalidone, which is hygrotin, over hydrochlorothiazide in the absence of heart failure or renal insufficiency. Use a loop diuretic over a thiazide in a class 3 or 4 heart failure, or if the estimated glomerular filtration rate is less than 30. You can continue the beta blocker and or calcium channel blocker beyond 3 years post-MI or acute coronary syndrome for treatment of hypertension without heart failure, reduced ejection fraction. Reduce coronary events in patients with diabetes. In patients with type 2 diabetes, start with metformin. If needed, add another anti-diabetic agent with proven cardiovascular benefits, such as Jardiance or Victoza. An ACE or an ARB is recommended for patients with coronary artery disease and diabetes to protect against diabetic nephropathy. Consider an A1C target of 7% or less for patients with recent onset diabetes or long life expectancy. A goal of 7 to 9% is reasonable for others that might have a hypoglycemic history, micro or macrovascular complications, or multiple comorbidities. Suggest a diet consistent with the DASH diet or Mediterranean diet to lower cardiac risk. Have patients aim for more fruits and vegetables, low-fat dairy, whole grains, poultry, fish and beans, and less red meat, sweets, and sugary drinks. Recommend limiting saturated fats to less than 6% of calories and avoiding trans fats. But this must be explained to the patient explicitly what these terms mean. Recommend healthier oils, such as canola or olive. Recommend limiting sodium to 2,400 milligrams a day for most patients, and possibly lowered to 1,500 milligrams a day for patients with hypertension. Explain that reducing sodium by 1,000 milligrams a day can reduce blood pressure. Weight loss of just 5% can lower blood pressure, lipids, and blood glucose. We will be talking about weight loss later in the semester. Encourage 30 to 60 minutes of moderate intensity activity, such as brisk walking, at least 5 days per week. Recommend a yearly flu vaccine. And choose the most appropriate options for helping your patients stop smoking. When the patient is post-MI or experiencing anginal symptoms, they are often more willing to stop smoking. Take advantage of this opportunity. This was a rather complicated discussion. You will encounter patients who present with an evolving MI, or you will have patients that have coronary artery disease or are post-MI and will need to adjust their blood pressure medications. Some patients are followed by a cardiologist, but others have insurance with high deductibles or no insurance, and you will be treating them. I hope that you feel better prepared after this presentation.